All right, hello everybody. Welcome back from the breakout sessions. We're going to call this session to order. And I know this is wonderful because everybody's talking to each other and you're talking about credentialing research and you're advancing some of the things you talked about in your sessions. Absolutely wonderful. So thank you all and congratulations. I had the pleasure as the moderator of this panel to go into each one of your rooms, and the discussion and the engagement is just what we hope for. So thank you for all of your contributions to help us think about these questions, and I am very confident that the discussion that we have about the perspectives of some of the gaps will be enriched by the conversation and your contributions to this discussion. So thank you so much. So the way we'll proceed is that each group will have a reporter, and they will report for 10 to 15 minutes. And after that period of time, we'll have about 15 minutes for 10 to 15 minutes for open discussion. So we'll start with group one. No, Joanne said go ahead. Okay, no, we deferred. So Joanne will be leaving abruptly at 12:30. So we have voted to have her go first. So Joanne, go ahead. Yeah, yes, of course.
Okay. Our group had a very wide-ranging discussion, which was great, that focused on, spent a lot of time on data issues, basic information gaps, and then narrowed in on our two kind of charge framing questions. So we can skip up to the next slide. The first framing question was, what is the most important knowledge and methodological gaps to resolve? And here we focused on knowledge, because for methodology, that also was kind of connected in the second question. And the methodological gaps that we believed that we had were actually largely data gaps, as I'll describe in a few minutes. And so, so there was actually a lot of, and the data gaps, we decided to focus on the second question. The reason we also did it in that order is that in the end, the data that you need comes down to the question of, what are you trying to answer? And so we spent a lot of time talking about all the different types of data we would love to have, and then said, all right, what do we think are the most important questions? And in general, there is actually a lot more on our notes than we have in our 5 items we were asked to try to narrow down to. But the 5 things that seemed the most important were the first question of, we don't even really know how many people are credentialed, what credentials they really have, and how they're distributed. We don't have good data on who's got these credentials. One organization might have data, but another one doesn't. From a national perspective, who knows, right? We don't really have any good idea. And even if we could pull together all of your credentialing databases to figure out how many people were credentialed, we don't necessarily know that they credentialed with one organization under their license in Nevada and somebody else's organization and their license in California. So really, where are they? And in what organizations do they work? What kinds of roles do they have? So there's some basic, just descriptive knowledge that is completely absent, that that there was a very strong sense in the room of, we just need to start by understanding the landscape better. The second area that people were very interested in, thought was a very key question, was, what is the value for the individual nurse? And there were kind of 2 domains of this. One was that whole question of, intrinsically, are people getting credentials because of their intrinsic interest in it? How does that connect to their engagement in their work, their engagement in their careers, their professional development? And perhaps to what extent is credentialing causing them to become more engaged because it's connecting them into a different community, versus these are the people who are going to be more engaged to begin with. And so that's kind of a whole set of questions around the value of credentialing for the individual nurse. Is it a signal of their inherent traits? Is it causal? Does it bring them into relationships and teams in a different way? How does that all play out? The third question was the value for the organizations that are employing credentialed nurses. And that value there certainly was discussion about quality of care and outcomes, which comes to number 4 there, but really it came down to cost. That if the economic value isn't there, organizations aren't going to invest in it or support it. And so there needs to be that demonstration of that economic value. Now, of course, to get to that point, you probably need to think about the pathways, which gets maybe stepping back a little bit to the question of, does credentialing improve the process for evidence-based practice? And it was very interesting to me, and I think to some others in the room, that while does credentialing improve patient outcomes was a question that was raised, the sense of the room was that really that question was too broad. If I took a bunch of data on patient mortality or length of stay and I merged it to a bunch of data on credentialing and found there was a strong relationship, the logical next question that a nurse executive like Linda should ask is, well, why is that? What were those credentialed nurses doing that resulted in lower mortality? Or maybe it was just an accident. I just happened to have them in a unit that already had lower, less risk. And so the notion was really, if we think that evidence-based practice is a pathway by which you get better outcomes, we certainly hope that's the reason it's evidence-based, then is credentialing helping nurses implement evidence-based practice more effectively, which then should be the pathway by which you get those outcomes. And ideally, perhaps, would get you the value as well. And then the final area where there was a strong sense we need to focus is to disaggregate the question. That it's not, that there has been a lot of research that has been kind of what % of nurses at the hospital are credentialed, but in some units it might be high, in others it might be low. Maybe matching matters. That there's disaggregation within the organization, but also if you have a nurse who is certified in critical care, but they are working in case management, that may or may not be the most relevant credential for that. Maybe it is. Maybe it actually does help, but maybe it doesn't. And so which credentials matter for which outcomes is really that deeper dive where the body of research needs to go. From there, we went to framing question 2. I like to say that this conversation was this orderly, but as we got down to the last 10 minutes, we said we better prioritize framing question 2 from this broad-ranging discussion we've had, which is really, okay, if those are the 5 research priorities that that one might put forward or say these are key issues, then how are we going to get there from the here? And what was really, there was a tremendous sense of agreement that the question is not methodologies. We've got big data methodologies. We've got translational research methodologies. We could spend a lot of time talking about fancy econometrics, epidemiology, biostatistics, and so on. There is a lot of statistical methodology out there that can be applied to all of these kinds of data, as well as qualitative methodology if you wanted to understand nurse outcomes and nurse engagement through qualitative methods. We've got a whole slew of that methodology available to us as well. The problem that we all have is there is no data. The data stink. And so we actually got off the methodology question quickly with a sense of, if you give any of us, any researcher a data set, they will figure out what the best methodology is for it, hopefully. That does kind of show up in our one of our points, but it's the data. And so the first thing that we came up with is you will have nothing other than individualized, isolated studies that are going to be specific to a single unit or a single little organization, unless there is a common data model, that there is a common way of collecting the data across HR systems or state boards or other organizations so that you could actually merge the data together, you can align it, you can be looking at the same thing, that there is some kind of standardization. And there are a lot of different places where that could happen. And so that maybe gets to number 2, that state boards of nursing do have recommendations available to them from the Forum of State Nursing Centers regarding minimum data set elements that they could collect. If you're doing a relicensure survey and you want to ask more than, name, social security number, and have you been arrested in the past year, that you also might want to ask, are you employed? What kind of setting? What is your job title? Have you completed another degree since we last talked to you? And those sorts of elements. There are about 14 questions that have been recommended. It's a published document that's widely used in developing these data systems. there is not an item in there about credentialing. I was like, oh, there's a gap. So that goes back then to you need to have a common data model, because I suspect that the folks developing that said, oh my gosh, credentialing is a quagmire. There are like 100 credentials out there. How would we make this a recommendation for a cash-strapped board of nursing to add a list of 100 certifications? So if you have some kind of a common data model for these data, you could then perhaps work with the forum to say, maybe this should be part of your standard minimum data set. Maybe state boards should be collecting this. They also, if they are going to be sharing such data with the NCSBN's data system, which is a vision of the forum and an agreement with the forum that ideally there is a repository for such data nationally, then you could have a common set of data nationally by which you could look at the individual nurse outcomes. You could look at a nurse's career trajectory. You could look at their employment settings over time. You could look at whether they pursue additional education, whether they're more likely to be employed, and so on, associated with their credentials. And do they drop their credentials? Do they maintain them? Which ones do they keep or drop? And how does that relate to their work settings? So there was that whole body of work. The other area where we need more data is the human resources systems, that there are these HR systems in almost every organization that could be leveraged if the data actually included credential information. And there was an allusion to that in some organizations, decisions are made about which HR system to purchase without any nursing representation in that decision. So then the nurse leader might say, I'd really like to have a little data field in here to record credential and then to record whether the credential was maintained. And if the data HR system was purchased in a way or configured in a way that it doesn't accommodate that, well, too bad, you don't get the data. So there needs to be, the nurse leaders need to be brought into these decisions and make sure that the information is there. Okay, that's great. We have all this data. Now we actually have to have access to it. And some state boards that collect minimum data sets have no provisions for a public use data set. I mean, as a researcher, I'm sure it'd be great to have everybody's name in there and do who knows what kind of data merges. But if I had a data set that had everybody's name stripped out of it and even just took it to the county level or the zip code level, I'd still learn a lot more than I do right now. From an organizational perspective, if a researcher could access organizational data that was standardized across 15 hospitals and then match it against their HCAHPS data or their other patient outcomes data that they're reporting to Medicare, then you could actually have a powerful study. But if you can't access the data, forget it. You can even go much richer with data merges. We used Jack Needleman's study in New England Journal of Medicine, where he was able to access data from a single organization and look at nurses on shifts, which patients were in what units, what the patient acuity system dictated staffing should have been, how short they were during that shift. And so you end up with kind of a dose of short staffing per patient and then can track down to outcomes. Those data merges are all possible if you give Jack the data, and then he can do all these merges for you. Yeah, exactly. And this kind of brings us to the last item, that there are many excellent nursing researchers who would love to get their paws on all of these data and do work with it. And if the data exist at a very good level, it would be really a shame if the best you got out of it was a bunch of crosstabs. That there are anywhere from crosstabs to sophisticated methodologies that can be brought to bear that can really help us understand the relative importance of the individual nurse factors versus the organizational kind of invisible architecture versus the patient characteristics. What is the relative importance of all of those in determining the outcomes of interest, the processes of care, the costs, the whatever it is you might be looking at. So there's a lot of good methodology there. And nursing researchers need to know these methods and be able to use them, or find Jack and, find a collaborator who can do that. There are nursing researchers who are tremendously good researchers who might not be epidemiological experts. And so I bet they have an epidemiological colleague nearby who could help them out, or an economist, or a generalized health services researcher, or they could do mixed methods research, or whatever the case may be. So the data analytic methods need to be brought to bear, and there is an ongoing need for nursing schools that are training researchers or nurses who pursue their doctorates in public health schools or other academic disciplines to really learn the right tools, so that when we get all of these super cool data, we can actually use them properly. And so I pass it back.
Absolutely. So thank you so much. See, pretty impressive. Lots of good discussion and digging deep on some of the issues that were introduced yesterday. So I certainly took lots of notes. But what I'll do at this point is open the floor to you to ask some questions of Joanne, so we can tease out what they learned in Group 2 through their discussion.
And I invite my fellow Group 2 mates to correct me or pitch in.
So I'm going to start because I think one of the big takeaways was the importance of this common data model. And when you think about how can we make that happen, tell us a little bit. So you had talked about the creation of or addition to a data set, the minimum data set related to nursing characteristics. So tell us how we can unfold and create this common data set, and who would be involved, and how would we go about it?
Well, so I can speak to the state boards of nursing component of it. There is this organization of the Forum of State Nursing Workforce Centers. I think it ranges from between about 25 and 30 centers. Some open, some have unfortunately closed. But as a group, they have developed these minimum data set recommendations. And so there would be an opportunity to collaborate with that group. They have a very good data and research committee. I'm not sure what the committee is called, but they have some very good people involved in that body of work who could be approached to say, okay, what kinds of things could be collected here reasonably? Are there any states that are collecting anything? And could you use that as a launching point? So that would be one area. I think I would also pass it on to Muriel and Roy, who are both much more of the informatics people who could speak to the kinds of organizational or institutional strategies. So I'll let them. Oh yeah, go right ahead. Yep, the microphone's got to come.
Unless you want to stand right here to get started.
Yeah,
You can, yeah.
there you go.
So one of the things we did in our group was identify some of the research questions that we thought were a priority to answer. So one way to start would be to take those research questions and to identify, okay, so what is the core set of data we need to answer the research questions? And then you start, that gives you kind of a minimum data set that you'd need to start with. So I think your idea, Joanne, with looking at what people are already collecting, but then saying, what are our priorities? What are the low-hanging fruit? Identify the data elements we need, and then start there, so we don't try to boil the ocean.
So can you just tell us who that would be that would generate these questions and prioritize the questions? What kinds of people would we need? Is it the people in this room, or are there others?
Well, I think we have to have I think we need stakeholders from nursing, from the state boards. I think we have to identify who are the stakeholders that would benefit from credentialing and make sure that they're all in the room and we get some agreement.
And that's where the employers came in, and why I pointed at Roy over there, because when you're looking at the data systems that chief nursing officers should be getting in there and saying, I want the next HR system to have this, that, and the other thing, there are, if I understand correctly, that there may be processes by which there could be more standardization across systems.
Yeah, if we had common core data elements and data definitions and data characteristics or attributes to each of those data fields, then we would be able to apply those across different industry settings, as well as within HR, within staffing and scheduling system, within workforce delivery systems, with other types of tool sets that fall under HR. We could gather those data sets. We could do it by consensus, by developing a consensus structure among the current credentialing organizations, as we did in the nursing minimum data set. Gosh, I am aging myself. In the 80s, and we could then roll it into one of those core sets. The only person that I would strongly be sure that we had would be someone who's a true nurse informatician with a computer science background as well, to understand the power of the machine, so that when we define the data elements, that we can move to a public data set that you can do research on, or otherwise you could get your flat files and relational databases all messed up, and we'd be in a lot worse shape than we are now. But it would be good to have someone of engineering background, like a Patty Brennan.
So there,
Patty appreciates it.
and the employers were considered really important in this, because on some level, what can drive more credentialing, or what really should be driving it, is what is the value add in terms of patient outcomes, quality of care, and so on, but then also follow the money. If an organization is not going to find financial value in encouraging credentialing, or market competitiveness value, right? You're not going to get a bigger share of the patients in your market, or there's going to be some value there for the organization, then they're not going to support credentialing. So those organizations have a very clear stake in they should want to know the answers to these questions. If I have more nurses certified in critical care, am I going to get better patient outcomes? Are my HCAHPS scores going to go up? Am I going to have fewer rehospitalizations and have fewer penalties, and so on? So those stakeholders have to be involved in helping to define what goes into the data set of their HR system, and then they also have to be invested in letting Jack get to the data so he can do his magic study.
And one of the things we have to remember is the industry service for HR is not specific to the healthcare industry. It covers multiple, so we would have to have some way in order to be sure that we brought in all the different suppliers to be sure that they knew actually just send the common data sets to them and they would put them in. Where did I get this? Muriel,
Let's see, other questions? I'm going to keep on asking. Oh, good, Pam? Please. Here it is.
So this is consistent with one of the last recommendations in the Future Nursing Report, which is better workforce data. And so let's assume we figure out the funding and the mechanisms to actually create this data model. Did you have a discussion about what other levers do we need to push with Bureau of Labor Statistics, or any other group that is going to be in a position to say, to also add credibility that these data are important to collect, so that it's not just left up to every setting where a nurse practices to have a willing group that says, yes, we will include this data model, or even these data elements?
There was reference to HRSA. Of course, HRSA has a Bureau of Health workforce that used to be the Bureau of Health Professions. They just did a big reorg. And so the Bureau of Health workforce has been engaged in helping to define minimum data set recommendations across multiple professions for relicensure surveys. And many of the recommendations of the Forum of State Nursing Workforce Centers fed into their recommendations. Of course, they were trying to come up with something that would work also for physicians and pharmacists and blah, blah, blah. So they're in a position to help provide the technical assistance, provide some rah-rah, let's do it. But from a cost standpoint, because every state licensing board is responsible for licensing and renewing licenses of their own nurses, the model has been in this country that those state nursing boards would be responsible for collecting the data themselves. And that Bureau of Health workforce has actually had their funding, the National Center for Health Workforce Data and Analysis has had their funding zeroed out multiple times over the past decade or two. So I think it would be risky to rely on them to actually be able to financially support the data collection from a national perspective. They just don't have enough money to give to every state board to do this. But they can, and they do have enough appropriation right now to provide technical assistance, to provide recommendations about what elements should be collected. There's a lot of national interest and concern about the adequacy of our health workforce to meet future needs. And the Institute of Medicine recommendations from the Committee on Nursing were not just about nursing data. They actually were recommendations about all professions, interprofessional data collection, and specifically recommended that HRSA have a key role in that. So I think the piece that's been missing is saying, credentialing matters. And it may matter also for physicians. Are they board certified, board eligible for other professions as well? And so can we leverage that process that HRSA is engaged in to help us move these ideas along?
Let's see, other questions. I'm going to put Dr. Burns-Bolton and Karen Haller on the spot now. I'll just give them a heads up. So there's a recommendation for standard data elements, and the two of you are the ones that are leading major organizations. Is this something that would be useful to you? How would you use it, and what kind of barriers would you encounter to incorporate these measures into your human resource system?
Well, the good news is I'm already influencing our HRIS system because of the need to continue to answer the question, of how might we do a better job at getting people cared for and getting them out of hospitals as soon as possible, and what are the data elements that most positively affect that. And to do that, I have to have access to, who the people are, what credentials they have, whether or not they are not just credentialed in terms of nursing, but degree to which they're credentialed in terms of team steps or any of the other programs that are out there about how well teams work. And so in my organization, and I don't know if Karen came back in, and I think the same is true in Hopkins, there's a cross-disciplinary team made up of executives that are continuously influencing the information system in terms of here's the minimum things that we need to make sure that are in there. So I can tell you now what % of my staff on what unit is credentialed, but that's matched to the nurse sensitive indicators outcomes dashboard, which is also matched to the core measures, and we go on and on and on. But it couldn't do that if I didn't have the two systems, the HRIS, Human Resource Information System, and the clinical data repository talking together.
Well, thank you. And I know Dr. Haller doesn't have a microphone, so I'm not sure if you have anything to add in terms of adding standard nursing data elements, including credentialing, to your human resources data infrastructure. So one of the needs was around some standard data elements. And what does that do for you in terms of managing a large system of care?
Yeah, I think it helps tremendously when we have standard data that we can look at by nurse, by unit, and that we can maintain, and it stays current, because with credentialing, the number of people you have changes and the number of people who maintain their credentialing changes. So I think it's essential to the work we're proposing.
And I should add, when we talked about the that number 2 state boards, I think I also omitted to say that a piece that could be added to that is if you do a survey when people relicense, people report wrong. There was some discussion of this where people put in the wrong organization for, who their credentialing body is, or they'll just put pediatric nurse practitioner credential, and there are like 3 or 4 different organizations that could be from. So it would be the ideal, the dream world, is every state is doing a minimum data set, every state is putting it into NurseSys at NCSBN, and then the credentialing organizations are also submitting their data. So you have a verified source there. And that, of course, would probably require some kinds of permissions or disclosures with your, with the people who are credentialed with you regarding appropriate data sharing. And ideally, then you would also have a process by which NCSBN would make a public use de-identified data set available for research purposes.
Hi, I'm Carol Hartigan from American Association of Critical Care Nurses. And for 16 years, I've begged National Council for us to have access to their disciplinary data. And, our certificants are supposed to report to us when their licenses have been disciplined, because that's grounds for revoking certification. They don't always do that. But it's important for us as patient safety organizations to know when their licenses have been disciplined. But this year, at the August Delegate Assembly, we found out that we will have access to the disciplinary database for all those boards that do participate in nurses. And instead of typing in 87,000 certificates individually into that system, we are going to have the ability to do a data dump. So we'll be able to match. It was going to be through Social Security number, which of course we don't collect, but we will be able to dedupe our certificates. So finally, we will be able to get a push when a nurse's license has been disciplined, finally. So it's really exciting that we would also be able to get the boards to collect certification data, because I've always wanted to know if critical care nurses are more likely to be disciplined. When I worked for a board of nursing, I thought that that was the case, because we'd like to know if we need to develop resources for them. So, it's important information to have. This is very exciting, because boards do not collect information about certification right now.
Other questions? And so I don't know about you, but I think Joanne slipped something in there that didn't come up in any of our conversations. And she talked about physicians, three categories of physicians: those that were board certified, board eligible, and others. And it never occurred to me, so we talk about when is someone certified, when is a magnet organization display attributes of magnetism, but I just wonder what you think about categories of nurses: board eligible, board certified, and not eligible.
That did come up. And of course, every certifying body has their own definitions of eligibility and so on. But one of the questions that came up was, so what is the value for the individual to obtain certification, and how many people are eligible for it but don't bother? And so that was one of the many questions that were raised and kicked around during our hour and a half.
So it's on the radar. So great job for group number 2. Let me just shake your hand. Did they get everything? Everything? Is there anything they missed? All right. Good job. All right, next we'll turn back to group 1. And so who will be the presenter? So Jack, I'll turn it over
Well,
to
I'm going
you.
to start and